Good evening, Dr. Clarfield.
Good evening, Vlad.
Thank you so much for joining us today and for agreeing to this interview.
My pleasure.
My name is Vlad, and I am co-founder of Class Education NGO. In Class, we are dedicated to improving medical education in Ukraine, and your extensive expertise in global health and medical education leadership is truly inspiring. And I'm looking forward to this talk to get your insights that might help us to shape our initiatives more effectively.
I hope I live up to your high expectations. I'll do my best.
And I also want to express gratitude to BGHI, Bellagio Global Health Education Initiative, and its community for creating opportunities for networking so this interview is possible.
Amen.
Yep, so to get started, could you tell us a little bit about your journey into medical education and leadership? It would be helpful for our listeners to better understand the context of our talk.
Okay, well, first of all, if you look at my CV, you might think that I planned this. The truth is, I didn't. I always wanted to be a physician, and so I went to medical school, and I found just by by the way that I like to teach. And so when you're a doctor, if you're ready to teach and you're ready to teach for free, which I was, most medical schools will be very happy to have you, which was the case when I started my career after doing my residency, when I started my career at McGill University in Montreal, which is where I was back in the late 1970s, early 1980s. And at the time, I was just privileged to be able to teach medical students, and I did. And soon, for whatever reason, the dean chose me at McGill as the assistant dean of students. So I was responsible for the medical students at McGill University, and I really enjoyed that job a lot. At the same time, clinically, I was involved in family medicine and geriatrics, and I taught in those two spheres as well. I moved in 1992, I moved to Israel, where I became the head of geriatrics in the Ministry of Health. I did that for about 7 years, where there was some opportunity to teach, but it was mainly an administrative job in the government. But after that, I moved to the Ben-Gurion University, where I am today, and became head of geriatrics there. And was given, again, in a medical school, you're given ample opportunity to teach. So I taught geriatrics for many years. And then I was asked to be head of the Medical School for International Health, which brought me into the Bellagio orbit. And in that medical school, it was a medical school that was devoted to global health. So I became interested in global health and teaching in that. And that's kind of how I arrived where I am today. But again, I'd reiterate that this was just sort of by accident. I just fell into these roles. I didn't plan them. I enjoyed them, and I guess I was reasonably, good enough at them that the people above me kept asking me to do more and more, which I did. So anybody who's listening thinks that they can't have a career because they haven't planned for it, just stick around, offer to teach, and most places, most medical schools will be very happy to have your services. And if you're good at it and you like it, then you'll just move on from task to task, which is what happened to me. Does that sort of give you a little bit of in a nutshell, how I got where I am?
Yes, absolutely. That's a wonderful brief overview and also an inspiration for young educators who will
Right.
watch. So, isn't there something specific about geriatrics that inspired you, or some people that brought you to geriatrics? Because you said that something was just happening to you and you felt like it, but was it something specific about
Well,
geriatrics?
there were many influences. I mean, you don't go into a specialty for one reason. I guess I've always liked old people, but that's part of my personality. I always liked talking to old people in general. I liked what they had to say. I'm interested in history, so talking to old people, even before I was a medical student, I would ask them where they came from and what experiences they'd had. Once you're in medicine, this becomes something that your patients benefit from and you benefit from, looking into their past history, not just the medical history, but their personal history. So I like that, and I came from a family where old people were viewed positively, and I come from a culture, Judaism, which does also give a lot of respect to older people and still does to this day. So I kind of found that opportunities for geriatrics, which were many because the world is aging, came my way. And oddly enough, I couldn't quite understand it. I do now, but I didn't understand then why every doctor didn't want to be a geriatrician. Old people have lots of illnesses. They're a challenge to look after. They're very grateful. And there's a tremendous need for geriatricians. Again, when I went into geriatrics, I didn't know any of this. I just liked old people. And I remember somebody saying to me, "Oh, Clarfield, you're really brilliant." I said, "Why?" He said, "You saw the demographic imperative and you dove right into it." I said, "Well, the truth is, I didn't see it. I just looked after old people and found out later that the demography was on my side. I didn't do it because of demography, but indeed, if you're a young geriatrician or a family doctor or internist and you like looking after old people, trust me, there's a lot more coming down the road and you'll always have work to do." But again, I kind of fell into it due to my natural interest in older people. And now I teach young people, medical students, that if they don't like old people, because there's a lot of them coming, they better go into pediatrics, because all adult specialties have old people in them. So you don't have to be a geriatrician to look after old people. If you're a cardiologist or a respirologist or a hepatologist or whatever, the only two specialties that give you a pass away from geriatrics is the two P's, pathology and pediatrics. Otherwise, you're going to be looking after old people. So if you don't like them, stay out of internal medicine and stay out of surgery and stay out of gynecology, because all of those specialties have old people in them. But
It's
you don't
just
have to be a geriatrician to look after old people.
it's so interesting how you just shaped it. So everybody is a little bit geriatrician, slightly geriatrician.
Yeah, unless they pick pediatrics or pathology,
Yeah.
they're going to be looking after old people. Most specialties have a lot of old people in them.
And what is that something specific or something that attracted you about global health? Why
That's another story. Okay,
see
that's
it
a different.
positive?
Yeah. Well, I like to travel, and I hope to be able to visit you in the Ukraine one day. So let's keep that up as a hopeful possibility in the future. Um, wherever and my wife and I both like traveling. We traveled all over the world before we had kids, and then while we had kids, and then even more so after our kids grew up. And I always found it interesting wherever I went to look at the healthcare system there. So if I was in Mexico, or I was in Russia, or I was in the Costa Rica, or wherever I went, or all the European countries, I would try and walk into a hospital and sort of look around. And I found the most amazing thing about medicine and global health is no matter where you are in the world, patients are the same, and medical systems struggle with the same problems. They may have more or less resources. They may be in fancier buildings or less fancy buildings, but a sick patient lying in front of you, whether you're in Ethiopia or Ecuador or Israel or the Ukraine, it's the same sick patient. And I found that absolutely fascinating because everything around you seems so different. When you go to a different country, the language and the food and the culture and the buildings, you go, oh my goodness, I've never seen anything like this. India, I've been to India, Pakistan, Nepal. Whenever you see a sick patient, you're in this unit. It's a little bit like music. And I'm not sure we talked about this before, but I'm an amateur musician. And I found the same thing with music, that music is an absolutely international practice and language. Even folk music, which is my specialty, even if people don't understand the words to the song you're singing, there's a kind of ability to communicate internationally, transnationally, maybe not internationally. The same with medicine. So I've always liked that. Then, so I always just by my nature was always curious. But then this medical school for international health, which is what I ran for 10 years at Ben-Gurion University in Israel, the theme of that medical school was global health. So I had an interest before taking on uh, this task because I was taken on because I knew something about medical education. But the theme of the med school was global health. So of course I had to learn more about it. And then more laterally, in the last few years, I've discovered that I'm a unique individual. I don't mean that in a boasting way. I mean it in an accidental way. I'm very interested in old people in low income countries. And in low income countries, there are almost no geriatricians, but there are a lot of old patients. So running this medical school and traveling around the world and being a geriatrician, I found myself in a unique position of being, and again, this is not meant to be sounded boastful. It's just meant to be like, you know, I just happen to be there. There are very few geriatricians in the world, and there are very few geriatricians in the poor parts of the world. So my interest in old people in poor parts of the world has always been welcome because there aren't anybody there aren't any geriatricians in those places, and yet there are old patients, and the doctors with whom I deal with say yes, we're very interested in what you have to say because we look after old people, but we don't really know how to do it right. So can you help us? So that's again accidentally being in the right place at the right time. I can say I'm one of the only geriatricians in the world who knows anything about old people in poor countries, not because I'm such a special person, but just because I happen to fall into this interest and just because there are very few geriatricians in these countries.
Absolutely. It's interesting how your life, as you say, brought you to this, that now is seems to be a well-structured plan, thoughtful idea and like step by step. And but
None of the above. Don't
it
trust anybody in any industry or any that says, I got here because I planned it. Most people get to where they are because of good luck. I had good luck being born in Canada, moving to Israel, having a good education, having wonderful parents, a good wife, wonderful wife. I had a lot of good luck. And I kept my eyes open, and I'm interested in a curious person. It's not that these things happen to me totally passively, but I was sort of, I think it was Louis Pasteur that says, "Chance favor, discovery favor." What is the expression? Chance favors the prepared mind. No, yeah, I'll get the right quote for you, but you have to be kind of curious to start with, and then when things pass your way, you say, "Oh, well, that's interesting," and dig in. Like I'm talking to you. I mean, I had this terrific opportunity to talk to a young colleague in the Ukraine, a country that interests me very much, and so for me, this is as much a privilege as it is anything else, and that's the kind way that I sort of made my career by taking opportunities as they presented themselves to me. But most people, if you ask Bill Gates, and I'm not Bill Gates, but ask him how he got to where he got to, he just sort of fiddled around. He was interested in numbers and computers and engineering, and he was fascinated by the whole idea of writing code for computers. And the guy's a genius, obviously, but he fell into what he did because of a whole concatenation of events. Had he been born 100 years earlier, I'm not sure he would have been one of the most famous people in the world, only because things had to sort of be around. There had to be the right combination of technology, of capitalism, of freedom. He was apparently a very bad student, and he wasn't thrown out of school, but people tolerated him, and he became one of the most successful people in the world. And if you ask him how he got involved, my guess is he would tell you something similar to me. Not that I'm comparing myself to Bill Gates and what I've accomplished, but in the accidental nature of careers. I think you're young. It's good to have ambition and to say, I want to be a surgeon or I want to do this or that, but keep your mind open to opportunities as they present themselves. And there are in our field of medicine always opportunities, always opportunities.
thank you on that positive note for our audience. And I want to say that you served as a director of a medical school for international health
I
at
did.
Ben-Gurion University for nearly a decade, right?
Correct.
And could you share what that experience was like? What were the biggest challenges you faced, and how did you overcome them?
Well, I don't know if the biggest challenge, but there is a challenge when you're my age at dealing with generations that are two, three, four generations younger than you. So, for example, when I was a med school student, we were expected to read books, articles, journals, and nowadays, many students, not all of them, there's a tendency in younger generation, people younger than you, to sort of say, well, I don't really need to read. I can watch a YouTube. I can, pick it up here, pick it up there. The idea of going home and reading 10 articles that we assign in a course, some people do and some people don't. In my day, you wouldn't even imagine not doing the assignment. You wouldn't imagine, it didn't enter our mind. So that's an example of the kind of, I mean, I get along with young people pretty well. I've got kids, I've got grandkids. I try to be open-minded, but it is a challenge for people of my generation who believed in books, textbooks, articles, reading, fulfilling assignments. So that was one thing. The other thing, when you're a medical educator, you end up spending or 90% of your time with 10% of the students who are problematic. You don't, when you're the head of the school, the problems come to you. The students that are doing really well and are flying through the courses, they don't come to you because there's nothing for you to solve for them. So that's on the negative side. On the positive side, I think what I really enjoyed doing and enjoy doing to this day is designing and tweaking curricula, taking a curriculum, say, for how do you teach global health in internal medicine? How do you teach global health in pediatrics? How do you teach global health in obstetrics and gynecology? And I really enjoy that side of the job. And that's the sort of creative side of building a new curriculum and adjusting it, because as time goes on, through student feedback, positive and negative, through your own mistakes that you make, through good luck, you find different ways of teaching various subjects in medical school. So that, on the positive side, I really, really enjoyed the curricular challenges. And the other thing is, you never do this on your own. I was the head of the school, which meant that I was kind of the musical conductor, but no orchestra can play without violins and oboes and timpani. And, so I had my musicians that I brought together, the doctors, the teachers in a medical school, and asked them to contribute their skills and knowledge. And I enjoyed that. I enjoyed the coordination of the faculty and bringing them together and encouraging them. And we had a lot of faculty that didn't know that much about global health. So I had to teach not just the students, but sometimes the faculty. Sometimes I had people in the faculty who were brilliant in global health, but sometimes we didn't. And you had to bring them into the school and help them learn themselves so they could teach what was necessary.
Based on BGU, well, was BGU or is BGU a standard, like a classical structure medical school university that has medical school, or it's different? Then if it's different, could you please describe the like classic Israeli
Yeah.
medical education pathway that future
Okay.
doctor goes through?
So let's start with the classic medical school for Israelis who just want to be doctors in Israel. It's not that dissimilar from what you and I were talking about in the Ukraine. It's a 6-year program plus stage plus internship. And these students come to us without a first degree, as is the case in Ukraine. As the case is, most European medical schools are 6-year programs that people come to. Now, in Israel, all the boys and most of the girls go to the army after high school. So most people enter medical school a little bit older than might be the case in Europe, because if the European school doesn't have a first degree, they might enter medical school at age 18 or 19. Would that be the case in Ukraine? So
Yes.
our medical students in general in Israel will enter medical school when they're 25 or 26. after having spent 3 years in the army and then 2 years traveling the world decompressing. So that's the usual Israeli school. MSIH was one of, and there are five, now six medical schools like that in Israel, and they're devoted to training medical students to be doctors in the country. Those, the language of instruction and the language of everyday life in Israel is Hebrew. It's not English. So those medical schools are taught in Hebrew, and I taught in Hebrew. MSIH was an extra medical school that Israel had five regular medical schools, and three of those faculties had foreign medical schools, of which MSIH was one. It was meant to service non-Israelis who came to study medicine in Israel. And we see this in Europe. There are medical schools in Ireland and in Poland and in Italy that cater to foreigners. And that's what MSIH was. 2 years ago, and so it was taught in English to not to Israelis, to non-Israelis in Israel. Recently, the government decided that because there weren't enough doctors being produced by the regular medical schools, they closed MSIH to foreign graduates, foreign students. And now, although the school still exists, it's a 4-year program meant for Israeli students who have a first degree. So there's now at Ben-Gurion University two medical schools, a 6-year European style program and a 4-year North American style program, meaning that the students have a bachelor's in science or arts before they come. But they're all Israelis, even though it's taught in English for reasons, I think, too complicated for this. I can talk to you about it later if you want, but the idea is to teach it in English because, maybe to put it in 2 sentences, people in Israel understand that it's important for doctors to be educated, to be able to speak English and to write. And the very fact that this interview is taking place with you and you speak such good English, we want our medical students, Israeli medical students, to be fluent in English as well. So this school is taught in English, even though it's taught to people whose first language is not English. Does that make sense?
Yes, yes, of course.
So it kind of evolved over the years, but the theme of the medical school is still devoted to global health. So we hope that the Israeli students who come to the school will be kind of infected by the virus of global health. And although they'll be Israeli doctors, they'll be interested in global health and travel the world and also do what they can from Israel.
So besides the difference in the program, like 4-year and 6-year program that your like the BGU has two medical
Mhm.
schools, and one of them is
Right.
6 years, one of them 4 years.
Correct.
Besides that difference and the fact that the students of 4-year program, 4-year school, they have bachelor degree prior to entering the university. Besides
Correct.
these differences, um, do they differ in further, in like in residency, in fellowships, or?
No, once they have an MD from Ben-Gurion University, they come from two streams, and they then all have to do a stage, have to do an internship, enter a residency program in Israel, just like anybody else. So there's no difference once they have their MD.
You say the word stage, right? What is
Yeah,
that?
internship. Sorry, stage is I thought it was the European. It's called stage in Hebrew, but that's not a Hebrew word.
Uh-huh.
Internship.
Okay. Um, okay, so what's the typical internal medicine surgery residency internship duration?
Okay, the internship is 1 year, which is
Mhm.
after medical school, and then after that stage, after that internship, people choose their specialties. So take something like internal medicine. It would be 5 years. Surgery would be 5 years. Family medicine is 5 years. But most of the specialties are around 4 to 6 years with an average of about five. That's not a fellowship. That's say you want to be a general surgeon, you do 5 years of surgery. You want to be a neurosurgeon, you do say 2 or 3 years of 2 years of general surgery and then 3 years of neurosurgery. That's the kind of usual arrangement we have.
Mhm. Right. So to be a general surgeon is just 5 years of general surgery. To be a
Yes.
neurosurgeon, it's 2 years, and then you have some sort of maybe like a branching where you can go
Yeah,
to
yeah, yeah,
neurosurgery or
yeah.
cardiovascular surgery?
Yes, exactly, exactly. All of the surgeons, this I'll have to do general surgery to start, but they don't have to do 5 years of general surgery to be a general GI surgeon. But they do two or three. Depends on the program. They may be different. I'm not. I'm away from it, so you know I'm not an expert in it. I can find out for you, but I'm not. I can't give you the exact. I can tell you about geriatrics and family medicine, but not the other ones.
Okay, okay, I see. Well, in terms of matching process, how it is organized in Israel?
Yeah. So matching is done by, first of all, the government decides how many slots there are in each hospital. So it's not like an American system. So if let's say you want to go into gastroenterology, and there aren't and you'll apply, and if there's room for you, they'll take you, and if there's not, they'll say no. And you could, although there are very few unemployed Israeli doctors after internship. You could be unemployed if you don't if you don't make it into a specialty that you want and you're not flexible about those that have more room. So most people do, though. Most people, look, they have a long time to make decisions. They have 5 or 6 years of med school. They have a year of internship. They make their connections with the different specialties, and they sort of have an idea of whether they're going to be accepted or not during their internship, but not necessarily. There's no promises. You have to apply. It's national. You might find it easier to get into neurosurgery at Ben-Gurion University than in Tel Aviv, just because Tel Aviv is like the Kiev of it's not the capital, but it's the cultural capital, and it's the wealthiest city, and there's more symphonies and there's a beach, and there's all kinds of things that make it attractive to young couples. Whereas Beersheba, it's only an hour train ride away from Tel Aviv. But I call this Clarfield's law of relativity. The distance between Beersheba and Tel Aviv is half the distance between Tel Aviv to Beersheba. It takes people who live in Tel Aviv say, "Oh, it's so far away." And we go, "What are you talking about? It's an hour train." The people who live in Beersheba, they nip on the train to Tel Aviv because it's only an hour away. So it's a small country, nothing like the Ukraine, which is a huge country, but you probably have the same problem of center and periphery. And even though the distances don't justify calling Beersheba the periphery, it is considered the periphery. And so there's more, and there are more hospitals in the Tel Aviv area because the Tel Aviv area has a bigger population. So there are some sort of local differences in what people choose to do, but all of the hospitals and all of the programs are either good to very good to excellent. And they're carefully supervised by an academic body called the Scientific Council of the Israel Medical Association. And all of the units, the teaching units, are carefully accredited by the Scientific Council. So you can't go to a bad neurosurgery unit or a bad pediatrics unit. Some are a little bit better than others, and I guess depends on your personality and your interest. You might want to be, or where you want to live. Afterwards, what you choose to do, but they're all pretty good. Some of them are excellent and world class.
So students that graduate, future residents, they have no fear of, getting into all of the programs. They know that they will be a good specialist.
Yes, for the
So,
most part, that's correct. For the most part, that's correct.
and was it that way always, or you had some sort of reforms to make that happen, to make students
It,
not to fear to go, like, not to fight for the place in Tel Aviv?
well, yeah, I think, look, I've been in Israel for 30 years. Wasn't there before that, but in the more than 30 years I've been there, there have been units that have been closed for teaching. They're not closed to patient care. That's the Ministry of Health accredits the hospital for patient care, but good patient care doesn't necessarily mean all teaching units have to have good patient care. But you can have good patient care and not be a teaching unit because the people there are just good doctors, but they're not great teachers. So there are a few units that have been either not accepted for residency or have been closed to residents, not closed, and some units have been closed because they're, by the Ministry of Health because they've been reformed. Nobody closes. It's too small a country with too quickly a growing population to close a surgical ward. We can't afford to do that. If a surgical ward is not functioning, maybe the Ministry of Health might replace the director and do a reform. But we don't close beds. The population is growing like that, and there aren't enough beds, there aren't enough doctors, and there've never been enough beds, and there've never been enough doctors, and there never will be for the next 20 or 30 years, given the demography of the country. So residents don't have to worry in a general way about whether they'll get a slot. They might not get exactly the specialty they want, or they might have to start in specialty X and try and transfer to specialty Y. That does happen. But most people seem to be satisfied. And this is not based on a scientific study I've done, but my general knowledge, where I work in one hospital, my wife works in a hospital in Jerusalem. It's a small country. I know what's going on around the country, and most people get into something that they like, or they may not get exactly what they wanted, but they move to something else and they end up being happy, satisfied. But people go through residency and end up quitting. That happens everywhere. People leave medicine. That happens. It's not common, but it does happen. Or they go into business, or they go work for high tech, or they go work for drug companies. That is a phenomenon. And it's actually growing in the last few years, but it isn't a major phenomenon as far as I can tell yet.
Challenges or the difficulties that students see in going to, as you said, like regions or like suburbs or some rural areas. Do you aware of such ideas or thoughts that they have? And are there any system, let's say cookies that system,
Incentives.
yeah, that system
Incentives.
gives those graduates, let's say, okay, maybe you have so, and yeah, and please, what is elaborate on what is the ranking, like by what rankings graduates match to to their place. So, and once they see that they need to go to some rural area because they want to be, let's say, surgeon, and surgery places are left only in some regions that
Central.
are not that maybe considered to be like very fancy or something like
Right, right. So again, this comes back to relative distance. So Israel is about 450 kilometers north south and about 50 kilometers east west. It's an oblast. It's just a teeny weeny oblast of the Ukraine. It's small. So there are no distances in Israel. It may take you a while to get somewhere because of traffic, but there are no distances. So there are people that live in Tel Aviv and do residencies in Jerusalem and vice versa. I lived in Jerusalem the whole 25 years I worked at Ben-Gurion. I lived in Jerusalem and worked in Beersheba. It's an hour and a half train ride, an hour and a half car ride, pardon me.
Mhm.
And, because I didn't want to drive back and forth every day, I would sleep over in Beersheba a few nights of the week. But that's not uncommon in Israel, that someone will live in city X and work as a doctor in city Y, because the distances are not great. There have been intermittent systems of incentives to different residency programs where they would be paid more to go to Beersheba, to be in a certain specialty that would be paid a little more. We're a pretty socialized system. So people are paid more. This is not exactly accurate, but the system is such that people are paid more or less the same, whether they live and work at doctors, live and work in Beersheba or live and work in Tel Aviv. There are differences between doctors and specialties, but it's more because of what specialty you're in and whether you do on-call work at night, which is paid for separately, and whether you are the head of a department or not. But in general, there's a fairly even salary scale. So financial incentives can make a difference. But for whatever reason, the government, in its wisdom or lack thereof, runs these systems and then gives up on them, or makes a promise and doesn't fulfill it. So that has happened. Geriatrics keeps getting I make a joke with my friend, you keep threatening us with incentives, but they never come through. So the incentive is the position that's available. That's an incentive. In other words, if you want to be a doctor and you want work, you have to go into a residency where there's work. And so some people go into things where that wasn't their first choice. But I don't think that those people are any less happy than people that get their first choice, because after a few years, you see that people can be happy or miserable, not because of the conditions of work, but the conditions up here. I think that's more important than the differences in Israel between cities. As again, it's a small country, and you can find a nice place to live outside of Tel Aviv, just like you can find a nice place to live outside of Beersheba. And you have to drive a little bit or take a bus. It's not the end of the world.
Yeah, I think that for the country that doesn't have like huge distances and who is which is quite well balanced inside and the system that works
More
smoothly,
or less. More or less.
that might be a case, yeah, that there are no
I'm
major.
sure in Ukraine you must have problems of large areas where there aren't any doctors, or there aren't any neurosurgeons, or there aren't any pathologists. I'm sure I mean, I grew up in Canada, which is also a big country. And I know that there are areas of Canada to this day that are badly underserviced medically. And I'm sure in the Ukraine, that's the case. And the war must have made it worse because you've taken doctors out of the system and put them in the military system, and they're taken out of the civilian world. I don't know anything about it, but I'm guessing that this must have happened and is happening. So we're blessed in the sense that it's a small country. It feels crowded. We'd like some of the distances that you have in the Ukraine, but the fact that we don't have them means that in medical services, even though people complain all the time, oh, it's so far away to get to a hospital. I go, well, how far away is the hospital? 15 kilometers. I go, 15 kilometers? That's not far away. But if you live in a little country, 30 kilometers or 15 kilometers can seem a big distance. If you live in the Ukraine, 250 kilometers can seem not that far away. Am I right?
Yes, yes, yeah.
Yeah. Yeah.
Well, that's a good response. Thank you. Thank you. And well, okay, let's go. Well, yeah, one more question about the
Sure.
matching. What are the grading system? How your residents match for the some sort of step analog or
I no, I'm not. I don't want to answer because I'm not an expert in the system. I've been out of that for a number of years, so
uh
I can find that out for you from someone else. I don't want to tell you stuff that isn't accurate. So
well, but
let's leave.
mhm, so by the time that you was like actively in the duty, was it some sort of exams also, and by the results of the exams?
Yeah, yeah. It was a combination of interviews, grades, the national your grades on it, and personal, not personal connections in the sense that if you knew the mayor, you get the job. As you did your training and you showed an interest in a particular specialty, you would get to know the director of the ward, and you would do an elective, say, and you would go in and tell him you want to get a position in his department. It's not as organized as the match. The way when you say the match, you're referring to the American match, the way the hospitals. It's a small country. There's only 22 hospitals in the country,
Hmm.
and seven or 800 medical school students that graduate every year. So people find their way. It's not as formalized. Again, it may now be more formalized than it was, but I'm not the expert in that.
Okay, so let's go back to the time when you was a director. And what was the structure of a faculty of a medical school? What are the departments?
Yeah.
How everything was
Okay.
organized?
So I think as we were discussing, a couple of days ago, there's a president of the university, and then the rector of the university who's elected. The president is a position that the board of directors of the university chooses, together with some government people. But under the rector, there are faculties of health sciences, humanities, engineering, basic science, etc. So we have a faculty of health sciences. Under that faculty, there's a medical school, a nursing school, a pharmacy school, a physio school, and a school for medical emergency medical responders, ambulance responders. We have a very good system of that in Israel. It's well organized and we know what we're doing. So the Faculty of Medicine has a dean that is elected by the faculty. I don't know if the Ukraine, how are the deans chosen? Are they chosen by the government, by the university?
So faculty deans, I think that they, well, I shouldn't maybe answer the question because it might be,
You're not sure. Okay.
yeah, I'm not
In
sure.
Israel, okay, so I can tell you that in Europe, they may be the deans may be chosen or appointed by the rector, but in our case, the deans are elected. There's an election and there's a political element, which I think has its advantages and many disadvantages. One of the disadvantages is that in most cases, the dean of a faculty of medicine will come from the faculty. It's rare that deans come from another faculty, say Tel Aviv to Beersheba. It does happen, but it's rare, and that's because of the election. But people are elected, and they're elected for a term of 4 years with a possibility of repetition of that. So it's usually 8 years altogether. Under them, they have the usual departments and department heads. So I was head of geriatrics. And geriatrics is in the Department of Internal Medicine. So we were like a subspecialty of internal gastroenterology, hematology, geriatrics, emergency medicine, etc. Then there's the surgical specialty. So there's the head of surgery. And all of the heads of these divisions meet and answer to the dean. And there is a dean, an associate dean. I was an associate dean for a while. There's a dean for overall, and there's an associate dean for medical education, associate dean for promotions, various associate deans. And since I ran one of the medical schools, there was an Israeli medical school, an MSIH, I was an associate dean and I answered to the dean. I was fairly independent for this medical school, I must say. The dean basically let me do what I wanted, and I would go to the dean if I had a problem. And there's certain things that only the dean could do. But I had a lot of autonomy, which was very nice. So people belong to one of these divisions. So they'll belong to the division of internal medicine or surgery, and they'll answer to their department head, the head of surgery, head of internal medicine, head of family medicine, and those people will answer to the dean of the Faculty of Health Sciences, and that person is elected by the faculty members every 4 or 8 years, depending on whether they stay on or not. Does that help explain the structure?
Yes,
it's very simple. Yeah.
Yeah. And so while you was a director, do you think that medical school for international health at Ben-Gurion University was considered to be prestigious between students? Like, oh, I want to apply because it's a good school.
Yes. If you were interested in global health, again, I told you I'm the only geriatrician in the world who's interested in who knows anything about low-income countries, only because not because I'm the best, but because there aren't any. There are very few medical schools in the world devoted to global health. Lots of medical schools nowadays have a kind of track, especially American and European medical schools have a track for those students who are interested in global health. But to this day, I don't know of any medical schools that are devoted entirely to global health. All the students have to take all of the curricular offerings in global health. They can't say, well, I'm not interested in that. I'm not doing it. And I think, as I was saying to you before, one of the major elements of our curriculum is that students in fourth year, in the final year, they go abroad for 2 months. And right as we're talking, the students are abroad, and we have sites in India, Nepal, Peru, Sri Lanka, Ethiopia. And we send our students for 2 months in the final year to those sites where we have faculty, local faculty, not our faculty, but we go and visit the places. So yes, if you're interested in global health, MSIH was and is the school to come to, only because there aren't hundreds of medical schools that cater to the issue of global health. Although, as I said, when we started, and the school started in 1992, there were very few medical schools around the world that even had a track in global health. Now there are many more that have a track, so that you can go to Harvard or McGill or University of Toronto, where I went, and you can join a kind of track of an interest track. But the medical school itself doesn't have an overarching theme of global medicine, and MSIH is the only school, to the best of my knowledge, that does that. So prestige, I don't know if it's prestigious, but it's not like there weren't a lot of schools to choose from. Although you could still today, you can go to Harvard and say I'm interested in global health, and you'll have
Mhm.
you'll have some answer to that.
So this global health part, which is a huge part of Ben-Gurion
The
um,
curriculum, yeah.
curriculum of your of the medical school, what do you think it gives? How it enriches medical students? What is
Okay, so
the purpose?
that's a great question. So first of all, if you're interested in global health, we're the place to come. But let's say you come to our medical school and you're not interested in global health, but you come to our school anyway. It gives students a broader horizon than just the medicine that you're looking at, at today. And apropos of what we talked about, my career that wasn't planned, but that just happened, it exposes students to like I just got interested in global health because I'd like to travel, and I happen to like to go into hospitals when I traveled. My wife thought I was crazy. Why do you want this? Because it's interesting, like this is interesting to see how. So our students don't have to wait till they're 50 years old and have traveled a lot. And by the way, went into a hospital in Kiev, and went to a hospital in Bogota, Colombia, and went to a hospital in Kathmandu. We already explicitly trained them in global health. And global health has many elements to it, one of which is a kind of cross-cultural and anthropological side of medicine that we teach. For example, we explicitly teach how to deal with patients that don't speak your language. Now, in a place like the Ukraine, where most people speak Ukrainian, it's not a problem. But if you're in Romania and you have Ukrainian refugees, how are you going to look after them if you don't speak Ukrainian? So how to deal we teach everybody how to deal with a patient who doesn't speak your language. And we're pretty good at that. We also teach what's called cross-cultural medicine. So we have a 2-day active sort of OSCE. You know what an OSCE is?
Yep, exam,
Yeah.
practical
So
exam.
it's like an OSCE where we have 5 or 6 actors who are programmed to have a certain disease and come from a certain country. And we expose the medical students to that. The actor tells a history. You can't do a physical exam on them because they may not have malaria, but you can't fake that. But let's say you have a patient that just came to Israel from a malaria country and had a fever and doesn't speak Hebrew or doesn't speak English. So we go through these exercises to teach the students what's called a cross-cultural approach to medicine, where you're dealing with someone who may or may not speak your language, or may or may not, who may speak your language, but may come from an ethnic group that has a very different view of health. Are there Roma in the Ukraine?
Can you come up?
Roma, gypsies, Roma.
Oh, yeah, sure.
Okay. So my guess is when they come to the emergency room, because they come from a different culture than the typical urban middle class Ukrainian, you might find that they have health beliefs and ideas that don't merge completely with your typical Ukrainian view of medicine and health. I'll give you an example. I don't know what you think personally. You don't have to tell me, but I'll give you an example of a lot of Russian doctors and Ukrainian doctors came to Israel when Ukraine was still part of the Soviet Union between 1980 89 and 92. A million Russian and Ukrainian speaking doctors came to Israel. So I have a lot of friends in Israel who are from that period of time who came to Israel and had to retrain. They went to good medical schools in the Baltics, in the Ukraine, Moscow, Leningrad, St. Petersburg, wherever, and they came to a new system. Now they had to learn Hebrew, and that's a challenge, but they did. And I found that my Russian and Ukrainian doctor colleagues, who were very well trained, good doctors, they had a belief that a hypertensive patient could tell when they were hypertensive. I don't know what you teach your students, but my Russian colleagues were taught that a hypertensive patient can tell when they're hypertensive and tell when they're not hypertensive. Okay, is that the case in the Ukraine today or not?
Well, I don't think that there is some sort of like teaching about that. It's just from the maybe from the from the experience that people with the sub um, like 37 degrees Celsius, they feel like they are like shrinking, right? Uh,
Yeah.
and then when they are over 38, they feel like they are just too hot.
Yeah.
That's
Okay. So we know the temperature actually, there is something to be said. People can tell when they're febrile, they get cold. But hypertension, I can tell you a statement. Hypertensive people do not know that they're hypertensive unless their blood pressure is very high, in which they're having a hypertensive crisis and where their head is blowing up, or whether their blood pressure is very low, in which case they feel for various hypovolemia, for dehydration, drugs, in which case they feel, dizzy and unwell. Between those two extremes, I can tell you that patients do not know how high their blood pressure is. My Russian friends didn't buy that because they were taught that you can tell. And so we take something like that, it's called a health belief model. And if your patient, a patient from Russia or the Ukraine, an old patient of mine, comes to me and I say, your blood pressure is high, and I take their blood pressure and I see it's really high, I go, are you taking your medications? And they go, well, no, because I'm not hypertensive. I go, what do you mean you're not hypertensive? So because I don't feel hypertensive. I said, well, you can't tell if you have high blood pressure or not. They believe that they can. It's called the health belief model. And so we teach this explicitly. We teach how do you deal with people who have a different health belief model than you. Take something simple. We have Bedouins in Israel who are Arab who in the past come from a nomadic culture. And most of them are Muslims. Not all, but almost all. And according to Muslim religious law, a man can take up to 3 wives. Now, you can have your own opinion about that, whether you think that's the right thing to do or not. But if you're faced with a Muslim patient and you're talking to wife number 2 of 3, you have to know that. And you have to know how to deal with that. And it doesn't matter whether you approve or disapprove. You have to know that that woman who's having a baby is going to be a different kettle of fish, a different way of dealing with her than a middle class Jewish Israeli who may have, who's married to a Jew. And for Jews, polygamy is illegal. So there are no polygamous Jewish families in Israel, but there are quite a few polygamous Muslim Arab families in Israel. And although it's against the law, it's tolerated. So how you deal with that dilemma, how you deal with a cultural difference and be the best doctor you can be without being judgmental is what we teach. And that's relevant for whether you're practicing in the Ukraine and dealing with a Roma gypsy patient, in Israel dealing with a polygamous Arab Muslim patient, or you're going to Nepal and you're dealing with Nepalis and their health belief models that might be very different than yours. We teach that explicitly. We don't wait. You can be my age and learn it over 50 or 60 years, but that's not good for your patients. They should know, a 25-year-old doctor should know that, not wait till he's 75 like me to learn that. And we teach that explicitly.
yeah, that's a fulfilling answer to the cultural and conflict provoking topics that are covered by public health. They are prevented.
Right.
And I want to that I just realized that your question was about hypertension, not hyperthermy. That I
No, no, high blood pressure. Pardon me.
high
Yeah,
blood, yeah, hypertension, and
but
that's
no, but
that's
your error of talking about temperature was not wrong because in a high temperature as opposed to high blood pressure, patients do feel different. Whereas in high blood pressure, they don't feel different. But the Russian doctors said hypertension is like a high temperature. You can tell the difference. So
oh, I
the,
see.
the
Okay,
okay. Yeah,
okay.
go ahead.
Well, yes. So, we've covered the global health part and how beneficial it can be to the, enriching the mind and the world view of a physician. Let's say we want to build a good medical school that prepares wonderful physicians for the country, for the system. What are the necessary parts of that medical school from your experience that you had in multiple universities, seeing multiple people, multiple faculties? Some are good, some are wonderful, some are not that good maybe.
Right.
But what are the like one, two, three parts that you have to have and you have to work on them so your medical school will grow, your students will you will attract good students because it's also important to attract good students that will then be, you will build
Right.
on them
Right.
and they will be
Right.
good professionals. So some of those points that you should have to have an efficient medical school.
Okay, that's a tough one to answer, in less than 5 or 6 hours, but I'll try and summarize. First of all, I would caution you two things. Be patient and learn from the world. Now, you're a good example. I don't know if you're a patient person or not, but you're learning from the world. The very fact that you're interviewing me, you're curious about what other people do. That's a terrific quality. And that a medical school is never alone. A medical school can always learn from the strengths and weaknesses of other schools. And so you should do whatever you can to borrow knowledge, to find out what other people have done. And nowadays, it's very easy. In the old days, it wasn't so easy. Nowadays, it's very easy to find on the internet. You can find a curriculum. You can find Harvard. You can find almost anything. I mean, you can't find everything. You can't find everything, but you can find almost anything, if you know what I mean,
Yep.
on the net. So nowadays, it's not so hard to build a good medical school curriculum, but you have to have the right faculty and you have to have the right students, and they feed off each other. A medical school that has good students is going to be a better medical student than a medical student with bad students because they challenge the teachers and they success breeds success. So it depends. Your question depends on where you stand in the system. If you're a dean that wants to start a new medical school, that's one thing. If you're a young faculty like yourself that wants to contribute and make your medical school better, it matters where you're coming from. But I think the principles are be patient, learn from other people, be you've got to be excellent as can be to attract people. You have to be honest. You have to deliver what you promise and tell people what you can't deliver and not make promises you can't meet. But the wonderful thing about medicine is the people that come to learn from you usually are people that want to be doctors. You're not dragging people into the army and saying, like, you have the problem today and we have it too. You want to teach someone to be a good infantryman, and to be a good infantryman, you might get killed. Medicine is a great profession because most people who come to it, not all of them, most people really want to be doctors. So you're dealing with a curious crowd of people that want to get the knowledge you have. So that's a good thing. You have to have a budget that's adequate. You can do a lot of things with not too much money. It's always better to have more money. But I never went to a medical school, rich or poor, around the world that ever said they had enough money. Maybe in the Gulf, I haven't been there. I mean, I have been there, but I haven't visited. Oh, well, actually not true. I visited. They have enough money. They're rolling in dough. The Saudis, the Kuwaitis, they have too much money. That doesn't mean that they've got such good medical schools because they have too much money. But most people that I deal with and dealt with in my life, Canada, United States, the UK, Israel, no one ever thinks they have enough money. So you have to be efficient and use resources you have as best you can, and to do your best to partner yourself with other places. So a place, a country like the Ukraine, if your faculty could partner itself, and maybe you already do this, with richer, more developed medical schools around the world, either as medical school to medical school or faculty to faculty, if you said to me, our Department of Geriatrics wants to partner with your Department of Geriatrics in Beersheba. We want to send someone for 1 month to visit you. That's easy to do. And we do that all the time, in fact. So there's a lot of goodwill in medical education around the world to help we help each other and to help people that are less wealthy or less experienced than we are. So partner, be patient, use your resources efficiently, be honest, and take your time and build on your strengths. So let's say you have a particular strength in your medical school. That strength has to be maybe even given extra resources, because that's the beacon. Let's say you've got a tremendously strong cardiology department. You have to keep that department. It's kind of like a lighthouse that brings other people. And then from cardiology, well, there'll be cardiac surgery, and there'll be ICU, and there'll be emergency care. And then, of course, the other special, because the cardiologists, even if they're good, can't do cardiology without a nephrologist, without a respirologist. They can't do it all themselves. So work on your strengths, but don't just work on your strengths. I hope that helps. But it's a tough question because it's an ongoing process that takes many years.
Mm-hmm. Understand, and I appreciate that you still, knowing that that's a huge, broad question to answer. You try to, structure it and answer honestly. I want to elaborate on this question slightly to specify. I think that one of the most important things for not just for medical school, for all organizations, companies, where people gather together to do some things together, it's what are those people like who gather, like when you are surrounded by, let's say, like-minded people, and they all are like targeted at one good aim, that might work, that should work. When there are some problems with setting everybody to look at one beautiful aim and go together to it, there might be problems. So my question would be, from the experiences that you have and from places that you've seen, um, how to attract good medical educators to the medical school, and how to keep them motivated to stay in medical, and because they are mostly clinicians, or from basic sciences like anatomy, histology. They probably work in the lab or on some science project or stuff. How to keep them motivated to
Okay.
spend their time teaching students?
Okay. So first of all, that's an easy one, actually, because um, not all, but most doctors like to teach. It's a profession that there's a kind of inbuilt. Many of us like to teach and want to teach. Not all of us, but most of us. What you have to do is encourage these people and give them support. So something as simple as a monthly medical education lunch. Every first Monday of the month, between 12 and 1, we're going to sit together and someone's going to present a problem in medical education. Teaching physical diagnosis, the student that lies, how to set exams. There's a million subjects. every week, every month, or every week, if you've got enough interest, someone's going to, and you, Vlad, you've got to organize it. Someone has to take the leadership and say, I'll organize it. Okay. I want you guys to send me, each of you send me 3 topics by email that you'd like to talk about. Okay. And I'll pick, if 2 of you want to talk about physical exam, I'll ask one of you not to. And the other, there'll be a match. Give me 3 topics and I'll match. And then every first Monday of the month, we're going to meet. Then you get these people together and they meet and they start to help each other and talk to each other. And then you say, you know what? This guy Clarfield, he's a sucker. He's willing to talk to us for nothing. Okay. And we're in the time zone with him. He's willing to have a Zoom with us, and we'll set up a thing, and we'll ask him questions about medical education. You've already got a group of people who've been working together for a year or for 6 months, and you bring in someone like me. There's lots of people around the world who would be very happy to talk to you about a particular subject, to give a talk, to give a presentation, to answer questions. And so you build a cadre of people that are interested in exams. And let's say you've got a problem where the students are complaining the exams aren't fair. You've heard that complaint before? Okay. So there's a literature about this. There's a way to write questions. There's a whole science about how to write medical school questions and how to validate them and to assess them. I'm not a big expert in this, but I know enough about it that I would bring in people to help me. So if you're having trouble with exams, there's a literature. There are people outside. One of the people that your medical education group, you can say, you know what? Look into this. I want you to look into this question a bit and prepare something for us for next month. It's all there on the internet. People can read about it. So I think you have to make a place where a place doesn't have to be a place. It's good if it's a place, because I don't like Zoom meetings have their benefits, but there's nothing like an in-person meeting. So if you can get people together in the same room, that's best. If you can't, okay, you do it on Zoom. It's less effective, but it's better than doing nothing. So I think bringing like-minded people together and assigning them tasks will generate. Some people will be interested in different aspects of medical education, just naturally. If you throw a bunch of coins up in the air, some of them land heads, some of them land tails. You'll find people are interested in different. People say, "I like medical education." You'll say, "What's interesting?" I'm really interested in the bedside teaching. I'm really interested in exams. I'm really interested in OSCEs. I'm really interested in how to design a curriculum. I'm really interested in feedback from the students. Do you get feedback from students? You have a formalized system of feedback?
Can you please tell how it is organized in your country? Because
Yeah. So we at Ben-Gurion, I can tell you, and it's more or less the same. It's extremely well organized and has been for many years. Every course, every major course, the students have to fill out a question, like a questionnaire about the course, and the class has student reps that are representatives that are meant to come at the end of the course and discuss the feedback that the students, or complaints that the students have had about the course, to the course director. So you can hear things about the course that went well or that didn't go so well. Okay. The students feel empowered because they don't just complain and bitch to each other. But that's all medical students complain to each other. That's right. If you don't know how to complain to your friends, you're not a real medical student. But you want to make that into something positive, a force for good, a force for positive change. So it's extremely well done. And so the students, when they complain, as they do, we say, okay, bring your complaints to the evaluation session. We want to hear them. Every complaint is an opportunity. You might be right, you might be wrong. And if you're wrong, we'll explain to you where you're wrong. And even if after the whole process is over, the students aren't convinced, at least they've had a chance, like in court, they've had a chance to make their case, which makes for students who are happier students who know that the faculty cares what they think. They can't always accept. I would say to students, my algorithm is very simple. Give me a complaint. Here's my algorithm. In my view, either your complaint is justified or not justified. If it's justified, either I can do something about it or I can't. But that's my simple algorithm. And I think the students appreciate it. I said, listen, I hear you. I hear what you're saying, but I don't agree with you. In my experience, but thank you for that complaint. Sometimes I say, oh, I didn't know that. Whoa, thank you for telling me that. And then I say, complaint justified or point well taken. Can I do anything about it or not? And sometimes I don't have the resources, be they financial or the people. And I say to the students, you know what? You're right. You're really right about this. But unfortunately, I can't do anything about it. But thanks for letting me know, because this is a medical schools are a work. You're here for a certain number of years. I'm here for longer. And sometimes we can't solve the problem when it's presented. But 2 years from now, I get the resources. A person like Vlad comes and I say, Vlad, you're interested in this kind of, blah, blah, blah. The students have complained for 2 years about this. Can you fix it? And you get Vlad who says, yeah, this is a great problem. And you solve it after 2 or 3 years. So that's how it works in Israel. And Ben-Gurion has been a pioneer. Now all the medical students do it, and they do it pretty well. The problem, I'll tell you, which is really surprising, which might surprise you, is the students get very complacent and they don't fill out the evaluation forms.
Why?
They're complacent. They figure they don't care. They're happy. They could be happy, and so they don't give evaluation. They could think, I'm going to fill out this form, but no, nothing's going to happen. So why should I do it? And students are less compliant than they used to be. Used to, like in my day, if they told you had to fill out a form, you filled it out. You didn't even think about it. Now students say, well, I don't have to do that. I'm busy. I'm going for a beer. Okay. So despite the fact that we have this well-organized system, sometimes the biggest problem is the students' willingness to engage. And so then I would go as the head of the school and have a class meeting. We discuss, say, listen, guys, there's a problem with the evaluations. We're not getting enough feedback. If you're happy, let us know. But your lack of response means either you don't care or you're too busy to let us know. So I'd like to encourage you to be more receptive to the feedback sessions. But there's a life cycle to this. When you start this in a medical school, it's usually very popular because the students have never had an opportunity to complain. If you set up a mechanism for complaints/evaluation, for the first few years, the students will be very compliant. As things get more settled, they say, oh, I don't need, I'm too busy. But that's a wrinkle. That's a minor thing. We have a very well organized system that works. There's a department in the faculty. There's a department. It's not that geriatrics has to do this. Geriatrics has to fill out the forms. We send them to a department of medical education that then works on the data and sends me as head of the department an evaluation with graphs and numbers of student satisfaction and written text about, where things were very good or where things weren't so good. And in that way, you're able, coming back to your question earlier, how do you make a medical school? It's a system of constant adjustment and constant improvement, where you try to look for, if you choose the capitalist model, if you're a very clever airline, if you really run a good airline, you really want to listen to the complaints of customers. You want to have a big customer complaint department. You don't want people to wait for 35 minutes online while they're listening to music. If they have a complaint or a website that's impossible to navigate, you want to make it easy to complain. Because if you make it easy to complain, you will learn what's going wrong in your institute, in your organization. And that's something you have to have a certain maturity and not take it personally. Because sometimes students complain about the stupidest things. They're completely wrong. They make a complaint, but I know, because I've been doing this for 30 years, I know that complaint is bullshit. And I don't say that to them. I say, oh, that's very interesting. Thank you for pointing that out, but blah, blah, blah. And I'm sure the airlines have the same problem where someone complains about baggage and you go, well, how long did you wait for your baggage? I said, I waited 3 minutes. Oh, really? Do you mean that as a complaint? Yes, I waited 3 minutes for my bags. And what are you used to? I'm ready. I expect someone to run out from the belly of the plane with my bags and say, "Is Vlad around? Here are his bags." So people make complaints about stupid and unjustifiable things, but within the universe of complaints, there's often stuff that you didn't know because you wouldn't know about it unless somebody complained or pointed out to you. So that's a big part of improving your medical school. It also shows your students you're serious, that you respect them, you respect their views, even if you can't always meet their needs, but you listen to them.
Can it be a thing for maybe not your medical school, but for other medical schools that they just don't feel like they want to fill this form, this feedback form, because they afraid if they will complain about some professor, let's say, there will be some sort of negative
Right.
predisposition
Okay.
to the person because
Okay.
like he complains about our like family member, our
Yeah.
faculty
Yeah.
member.
Yeah. Yeah. So that's a question of trust. First of all, the system of let's not say complaints. The system of evaluation is anonymous. People fill it out on computer, and we don't know. We just get the numbers, and the students know that, and they know that did Clarfield give a good lecture? Five excellent, one terrible. They just push a button. They put three or four or two or five, and there's no way I know who makes a specific evaluation. Um, with respect to the class representatives are meant to collect the verbal feedback from the students and present it to us as an issue, not that Vlad said this. We say one of our students found this, or we had a few of our students complained about that without names. So there is, we try not to make it possible. Now, that that whole issue of trust is one is well beyond this evaluating a course. Because yes, even in our enlightened system, take the problem of sexual harassment. Take the problem of women medical schools being harassed by old men like me. In the old days, this was very common in Canada, United States, Israel. Sexual harassment was very common. With time and the change in society, it's become it's become unacceptable, not just in medical schools, but in airlines and in factories and everywhere else for powerful men to not be allowed to exploit vulnerable young women. That's a general secular trend in society, we hope. And so the medical schools are now part of it. So the university has a sexual harassment officer that anybody can complain to anonymously. And that officer is responsible by law, it's even a law in the country, to investigate this. So yes, people are still afraid to complain about delicate issues, they are, but they're much less afraid because there are certain laws in the country and regulations in the university. And now people, to get new faculty, have to read and fill out a questionnaire about sexual harassment so they understand what's allowed and what's not allowed. So it's push and pull. Complaints are dealt with, and also teaching people, because sometimes people just they don't even understand that what they're doing is inappropriate. And there are norms and rules in society. What is judged to be appropriate or inappropriate is codified, and you can disagree with them, but those are the rules and you have to live by them. So trust is a big issue, and we talked about it much earlier on. The students have to trust the faculty and the dean and the officers that their goal is to make that student the best doctor he or she can be. That's their overall goal. And students have to trust that you really mean that. Even if you don't like the decisions we make, they're based on, I had to fail students. When you're head of a school, you're the one that has to say, you've done all the exams and I have to ask you to leave the medical school or repeat the year. I never met a student that said, "Oh, Professor Clarfield, thank you so much for pointing that out to me. I really appreciate it. I can't wait to repeat the year." Every single one of them said, "What? I did this and I did that, and you're wrong, and this and that. And I would listen patiently and go, okay, I hear you. But look, the medical school has certain standards. You've come to our medical school because you want an MD from Ben-Gurion University, and we have very high standards, and that's why you came here. So you'll understand that in order to keep our standards, we have to pass or fail according to the rules. So I don't expect students at the time to say, oh, thank you, I didn't realize that. I realize that as an educator, something I say to a student now, they might realize that I'm right 5 years from now, or 4 years, or 20 years from now. And I've had students come back to me and say, that was a pretty tough thing you said to me back in the day, but you know, you were right. Not everybody does that, but it happens often enough to know. You have to have faith in yourself, but you have to be a fair judge. And the student should not think that you're ever doing anything because of personal. It's all based on objective evaluations. And that's why the exam system has to be well done. You can't have a bad exam system and fail people on a bad exam system. You're failing people for the wrong criteria. It's like a radar for speeding. If the machine is not trusted by the populace, say you're going 110 kilometers an hour and you know the machines are faulty, you're going to not accept, understandably, a fine but if you know that those machines are actually accurate and that the policeman, when you get a fine, it doesn't go into his pocket, you shrug your shoulder and say, yeah, I should be careful how fast I drive. It's not a perfect example, but it helps, I think.
So it's like a societal consensus.
Mm-hmm.
So
Mm-hmm.
if everybody agrees that that's a true way of doing things, then they all like usually agree and then all.
That's the ideal. Now, not everyone always agrees. You have to sometimes you just say, tough luck, those are the rules. And again, talk about the difference between when I was a medical student and now. When I was a medical student, whatever the medical school said was true was true. We didn't think that we would complain to each other. We didn't think we had a way to influence the people upstairs. And that's generational. And that's probably a good thing in the sense that young people today are not as afraid. We were probably too afraid. We didn't complain at all. On the other hand, we accepted the rules and we didn't argue with them. It could be too far in one direction. Nowadays, many people will tell you that younger students feel very empowered and too empowered, and they don't accept the rules. I failed because I wasn't feeling well. So, well, okay, if you weren't feeling well, why didn't you get a doctor's note? Why did you come to an exam? We have a way if you're sick. Oh, I didn't think I had to do that. I said, well, we have a way of dealing with people who are sick for exams. You didn't follow the rules. I can't help that. So these are nuances. This is sort of like this is day-to-day stuff when you run a medical school. But I'm trying to give you the principles, not the details. The principles are be as scientific as you can, be as trustworthy as you can, try and learn from other medical schools, try and get help from people. There's a lot of goodwill in the system. A lot of this example is it's happening a million times where people from one faculty help someone from another faculty, or I'm learning. I'm also learning from talking to you. I'm learning about I have to think carefully about what I'm saying. I have to put my mind back. I have to make explicit what is perhaps implicit. So there's a lot of goodwill and a lot of willingness to trade and to help each other out, and you should take advantage of that.
And what are the advantages for the clinician to also work as an educator? And can you teach students being from not from the hospital outside of the university?
Yes, 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 yes. We have people like me who are academic physicians whose their whole lives devoted, and we have lots of clinicians that we get their help to teach physical examination or to take them into the operating room. They're not academic physicians per se, but we use their knowledge and skills to teach medical students. And what's in it for them? So what's in it for them? There's two things you can make people. You can offer them money, and some medical schools have a very financial view of teaching. I won't teach unless you pay me. That's one attitude. And we have people in Israel who are like that. And so I try and pay them. And if I can't pay them, then I have to go somewhere else. But most people, most doctors will enjoy, most, not all, will enjoy passing on what they learned to younger people. It's sort of a natural part of what doctors are like. Doctors have to be educators. I mean, you educate your patients. If you don't like teaching people, how can you be a doctor and explain to people what hypertension is and how they should treat it? There's an element of teaching in clinical work. So there's a bias. Most doctors will have some kind of tendency to like to teach in some way. In many societies, being a teacher in a medical school has financial implications, but it also has honorary. Many doctors like the idea that, oh, I'm on faculty. I'm an honorary faculty at Ben-Gurion University. The society values them for that. Now, who's a professor? Why am I Professor Clarfield, not Dr. Clarfield? Because I went up the ladder of academic promotions. Unfortunately, what we're talking about here is one of the most undervalued parts of promotion. That is excellence of teaching. For many years, people were promoted and got status and became hospital ward directors or professors based on their publications, not on their practice. And that's a big problem because just because you're a good scientist doesn't mean you're a good teacher. You can be a terrific surgical researcher. It doesn't mean that you're a good surgical teacher. And even if you are a good surgical teacher, teaching takes time. And until recently in Israel, teaching wasn't recognized, although it seems absurd, as one of the criteria for promotion. Nowadays, in most of the faculties, if you're an excellent teacher, that gives some credit towards promotion. So too does your work in the university, committees, and other, running an institute, and of course research. But the old bias that it was almost all research and not service and not teaching, that's changed. And your faculty has to give credit to people who teach, either by promotion or the annual we have a best teacher award. Every year, so-and-so gets the best teacher award. And when the students graduate, during the graduation ceremony, we say, and now we've come to a very happy, and I ran lots of graduation ceremonies, and now we came to one of the most pleasurable things that I do each year, and that is to give an award to the best teacher. And I'd like to call up on the stage Vlad, who has won the best teacher. Yeah. So one of the most happy, and I would say in a very enthusiastic way, Vlad, would you please come up to the stage and we give you a diploma and people clap and the pictures are taken and you go home and you say, whoa, all that teaching I did, that thing I did with Clarfield, and then I wrote the transcript up and then I published it and I gave it to the dean and I was recognized for it. So you can't recognize people for everybody for everything, but the very fact that teaching is recognized by a teaching award makes the other teachers realize that this is a skill and an approach that the faculty values.
And who decides who gets this?
So then we have a committee, there's sometimes it's just me. I just look around and say, who are the good teachers? Oh, Vlad, he's, because you can't award everybody. But you pick someone that everyone will say, yes, he's a good. And every year, I presided over 20 years of graduation. So over 20 years, I gave, sometimes we had the best clinical teacher and the best basic science teacher. So we could give 2 awards. Or we'd give the best surgical teacher, the best internal medicine teacher, the best, there's ways to do this. And it doesn't cost anything. But it broadcasts that the faculty values teaching, in addition to publications and running a good surgical ward, et cetera, et cetera.
That's something that we definitely need to implement in Ukraine, like this public recognition and appreciation of the work that should boost.
Vlad, it's free. You could do it tomorrow. If the dean agreed, you could set up a committee with 3 people and say, we're going to give the teaching award every year at the graduation. It doesn't cost anything. And it has it broadcasts a certain value system, which doesn't cost any money.
Well, and the last question regarding this faculty and building medical school thing, um, can the person, like, should you have an inborn qualities to be a good leader, or it's something that you can develop over years of practice and of seeing good leaders? I'm saying like leaders are everywhere in all the companies, like, and not only for medical school. But you definitely was in charge of teams, of making people work together, and the fact that you was in that position for a decade means that, like, at least nobody complained that much.
Enough. They didn't
Yeah,
complain
yeah, yeah,
enough. Yeah,
yeah.
yeah,
But
correct.
obviously, we think that was a good times for the teams. So yeah, what's your, let's say, secret, or what's your opinion on qualities that leaders should have, and can anybody be leader if they will
First
put
of all,
time?
anyone can be a better leader than they were before. So some people are born. Not everybody's Churchill. Not everybody's Zelensky. You've got an amazing president. The guy is head and shoulders above almost any politician today in the world in terms of his ability to communicate to the world, and I assume to the Ukrainian people, his ability to keep people together even though the situation is not good, et cetera, et cetera. So he's obviously a born leader. He was a comedian. I mean, he didn't go to leadership school. He just, he just fell into this. So he's obviously one of these people who's a born leader. However, not everybody has to be a Zelensky. Everybody can become a better leader or manager or operator by reading books, watching. People say to me, I'll tell you, this sounds like I'm boasting, but I'm not. People like the way I lecture. And and many times people have said, "Oh, you're a really good lecturer. How did you do that?" I go, "It's very simple. Very simple. I watched lots of lectures. Other people. I went to medical school. I went to university. I've been to lectures all my life. And I look at the good lecturers and I do what they do. And I look at the bad lecturers and I don't do what they do. And I'll give you an example, two examples. One, and we're coming to it's past an hour and a half, so we're going to have to end this soon because I never end a lecture late. I end a lecture 5 minutes before the time. Everybody's happy. You end a lecture 5 minutes after, and nobody's happy, even if you gave a good lecture. One. That's just an example of a very simple tool that you can be taught. And I'll give you another. And the other thing is on slides, don't put too much information on a slide. How simple is that? A recommendation. And you know how many people don't follow it?
A lot of people.
A lot of people. So if you do those two things, end early, not late, and don't put too much material on your slides, you're going to be a better lecturer. Yeah, and there's one more example of teaching clinical medicine, which I'll give you an example of. How do you let patients think you're not impatient? How do you let people think you're a patient person? So I'll tell you the truth. Naturally, I'm not naturally a patient person. I've learned to be patient, but it's not, hang on. There, you can still see me?
Yep.
Yeah, the internet is not so good here. Let's hope it works. I'm not naturally a patient person, but I've learned to act patiently. And I'll give you an example. Studies have shown, and this is a medical education study that anybody could do and you could get it published and become famous. If you go to the bedside of a patient and talk to them for 1 minute, you only have 1 minute, and you talk to them while you're standing, as opposed to when you're sitting beside them, beside the bed and looking at them, at their level. And you spend 1 minute sitting and talking or 1 minute standing, and you say the same thing in that 1 minute. The patient will perceive the interview that took place when you sat as much longer than the interview where you stood. Sort of like the distance between Beersheba and Tel Aviv is half of the distance between Tel Aviv and Beersheba. Okay? So tricks like that can help you in lecturing, in teaching. You can teach people a lot of stuff. Some people are more natural basketball players than others. What can you do? I mean, not everybody can play basketball like Michael Jordan, but everybody can learn with practice to shoot better than they did before they practice. And it's practice too. Practice is very important. I practice lecturing. I practice physical exam. I practice presenting to the president. You practice. Winston Churchill used to practice in front of a mirror before important speeches in Parliament. And my bet is that Zelensky, who is an actor by trade, probably practices too. And if you practice, you get better in anything, medical education or basketball. It's the same thing. It's a skill. And everybody can get better. Not everybody's a born leader. Not everybody's Churchill or Zelensky. Not everybody's Bill Gates, but everybody can improve. And I think that's got to be an underlying assumption that we make in medicine, that you can always be a better doctor or leader or teacher or all three.
Dr. Clarfield, so many interesting insights and ideas and experiences that you've shared. I see many potential spots where I would ask a lot more questions, but I understand that a concise interview and concise conversation is also a valuable conversation. I want to thank you for your time,
My pleasure.
for the experience, and for the passion. Yeah, especially for the passion you were speaking with, because it feels like you are a good lecturer. I can accept that, because you can tell from good lectures from I've seen in my let's say short life. They don't read from a paper. They don't try to, they just like, it feels you can follow their ideas because they are spoken in a way that is easy for the brain to process, because they are just going from the brain and to the brain. And it's so valuable to speak with you. And I hope that we will have some more opportunities to share experiences, because it's really valuable. I hope that you feel this honest.
Yeah, no, I'm glad. I'm happy to help you and your team. It was my pleasure, and I enjoyed talking to you as well. And I hope it was some help to you and your colleagues. Best of luck.
Absolutely. Thank you for this conversation, and have a nice evening.
You
And
too. Peace. Peace for both of us.